Welcome. Welcome everyone to the Health System Performance Network monthly webinar for Ontario Health Teams and anybody else who may wish to be joining us today. We have a really amazing and excellent lineup today. Thanks for joining us. We ask you when you come in, if you can come into the chat and make sure that you are it sounds I might be cutting out. That would not be good. I'm a hardwired, so keep me posted on that. If you could put into the chat where you're from, so let us know your name and where you're joining us from. Okay, and we have Diane from North Simcoe. I'm just letting everybody know. Mike from Rise. Mike, great to have you here again. Cindy from Ontario Health Kingston. Jillian Frank from Kuchiching. Kara Jajax from Care Partners, and now are coming fast and furious. Manila from SGCG, representing the All Nations Health Partners. Welcome. Way up in the north from Kenora, the corners. Sandeep from Closing the Gap. Gabby from All Nations as well. We have good representation from the north and All Nations today in Kenora. Renee Robinson from Bancroft. Family Health Team, so primary care. Christina Clark from Rise as well. Thank you, everybody. Welcome to the HSPN webinar this month. And we have an absolutely amazing one lined up with some really fantastic content, and it's going to get fast at some points because I think we're showing you a lot of knowledge and information that we've generated, and it's just the beginning of a conversation we want to have a lot more of. To activate the patient voice. I am speaking to you today from the University of Toronto, and for thousands of years, this land has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, it's still the home to many Indigenous peoples from across Turtle Island. I am grateful to have the opportunity to work on this land and to try and remember all of what it has been like. And as I come in along, what is now Dundas Street is a former Indigenous trail, and I ride my bike across there, and I think about the ways that the land was thousands of years ago, and sometimes I wish it was still that way. But we do have some advantages to having many people come together, and many people that we can host here at the University of Toronto, and virtually or in person. You're welcome here at the university. I see a lot of people that I know, but I'm also seeing a lot of new names. And so if we could launch up the poll, we're interested in knowing whether you've been with us before, joined us. And I think that this topic has captured a good amount of interest. We have over 100 people now with us. Have you joined us before, or is this your first time? Please click in. We will wait and be patient while everybody here joins in to this poll. It's a pretty easy one to answer. We're getting up there. A couple more people still to chime in, and we're doing very well on responses. And it does astound me the regularity and the stability of where this poll is going to land today. It's just amazing to me. Why don't we share the results back out? Almost everybody has answered in now, and we can see. And hopefully that you can see that 70% have participated before, and we have 29% or 30% are joining us for the very first time. And we've been doing this since 2019, so for 5 years now. And we have our overall average is very close to 30% new and 70% continuing. We have done some analysis. We'll have a report coming up on our website soon, updated about how often people are coming, where they're joining us from. And we will share those results out with you as well when they come in. We can take that poll down, and let's get on with introducing our speakers today. So I'm going to host. I'll just try and keep us moving and really highlight the amazing stories that we're going to hear today. first from myself introducing a little bit about what HSPN has done, but then we're going to hear about what our experience in equity measurement, equity stratifications around patient experience. So not just measuring experience, but looking at it in different subgroups. Dr. Grace Spiro, postdoctoral fellow here, will share that, and you've seen her before, I think. Also, we have with us today to talk about the importance of doing this work, Yasmin Sheikhan, who's a patient partner, but also a PhD candidate at the University of Toronto. We have a very special guest who will be joining us very shortly from Quebec, Dr. Marie-Ève Poitras. She is a research chair in patient reported experience and in optimizing primary care and how these two fit together and making sure that we're taking this knowledge and putting it into the hands of people who can make good use. And finally, some of our interest here is to understand what factors are really driving patient experience. And Emily Hamovich, PhD student here at University of Toronto, been running a lot of our surveys in the background, has done some very interesting analysis to help us try and understand what aspects of primary care and people's experiences really relate to their overall experience. So without further ado, let's first find out who is participating today in the participants, where you're from. We have a second poll here, and if we can pop that up. What role do you primarily play, or could you play in becoming a learning health system is how this is worded, but actually it's just in the health system. We're trying to coach, and if I had more material on how important patient-reported measurement is into a learning health system, originally, but given the amount of content that you're going to see today, we had to peel that back a little bit. Hopefully you've been part of our Learning Health System webinar series that we concluded last month. We ran that from last April all the way through to last month. 7-part series, all available online. And let's see, everybody here should be able to. We have well over 100 participants now. Everybody should be able to find themselves somewhere, including in that other role, at which point, and we're seeing a good number of people finding themselves in the other role. So I'd be interested to know how you would classify yourself and what type of role. I think that has slowed down. So maybe we can share those results now. And you'll see that we have with us today citizen patients caregivers, only about 8%, but we do have some. So I really appreciate your joining us today. Next most common are the professionals and the government, about 15% each, and then system or organizational leaders, mostly doing the work in Ontario health teams. I think that's why that ends up being the so many people from Ontario health teams today, from the leadership roles, from the staffing roles, and I think that's really, really important for us to play today. This discussion is very active and important for patients, family, and caregivers too. We're going to talk about some of the very specific ways that we're doing that well, and we're wanting to be very intentional about that work. Thanks for popping in those other ones. I see that there's a glip that we had researcher on this poll on the screen in what I meant to put in, but when we created the poll, we left that researcher part off. So thank you for popping those in, Vicky and others. It's really essential roles. Okay, I want to let just a few minutes here to talk about how HSPN has been involved in many efforts, and then we're going to touch on just 2 of these, especially today. But this is not new to us. So first, I'd like people to know that between 1999 and 2009, the Hospital Research Collaborative provided hospital-level reporting on patient satisfaction in an annual report every single year in emergency departments and acute care. And that work didn't exist before the hospital report. And for those people who are in hospitals today, you would say that's just routine. That's like what we do. We're trying to make the entire health system feel the same way. Next, we participated in an international study in quality and costs in primary care. So since 2013, for more than 10 years, HSPN has been doing primary care surveys of patient and provider experience. And I'm going to show up one slide on that experience. But our next effort was to also move into community. So we developed the home care client and caregiver experience surveys. And currently that is the tool being used in Ontario with over 9,000 clients every month. So in that home care space too. We're not going to talk about those results today, but they're out there and important. Next, we developed a tool specifically for Ontario health teams to use. We're revising that tool right now, particularly in the context of new approaches by Ontario Health and also the Paris study, which has influenced our thinking in this space as well. So in the spring, we'll be relaunching another tool to help complement everything else. And finally, today we have a very special knowledge event on the Organization for Economic Cooperation and Development, or the OECD, which is a global organization with 34 countries from around the world, who created a new way of reporting on health systems. The OECD does a lot of reporting on health system performance. And this is their first effort at using patient voice in the patient-reported indicator survey. And HSPN, we ran this survey in Ontario, and we were the data support for the program across all of Canada. And you're going to see some great knowledge about that, because we've been very active across Canada with our participant colleagues learning about patient-reported data out of there. So let me just say, what do we know about performance? On the next slide, the Commonwealth Fund has been doing some work on our work on patient surveys, and you have all seen this slide. Most of you have probably seen this slide, where Canada does not rank very well on the Commonwealth Fund. And we used to be, 10th out of 11 countries, and now we are 7th out of 10 on the Commonwealth Fund in the overall ranking. Although we do perform reasonably well in health outcomes and care processes, the Commonwealth Fund suggests that we are well down the list. However, the Paris study on the next slide suggests we might be a little bit higher up the list. So maybe it depends on what questions you ask. So here, out of 19 participating countries in here, Canada is number 2, 3, or 4. And in the area of equity, we have some gender inequities in some of our aspects of care processes. We're 6th. But you can see in this OECD study that we're going to talk about today, Paris, Canada ranked quite high compared to other countries. We have the Qualicopi C was an early study that I mentioned back and forth. And how you ask questions matters there too, because on the next slide, you'll see that, back one, that there. Canada here, if you just asked a yes, no question, how well do we score? And this particular one is people who said yes, that they had good communication in their, that the doctor understood what was important to them and involved them in making decisions, all above 90% on these 4 items across every province in Canada. So if we're just asking yes, no, sometimes we miss a lot of nuance. We could probably skip 2 slides here, Lale. I'm conscious of yeah. So just before we get on with our first bit on the Ontario surveys, I'd like to do one last poll about the people here. How have you included patient experience measurement in your plans? So whether it is included in your ministry agreement, whether it's part of your quality improvement plan, if it's just internal measurement and monitoring, and whether you're not using an experience survey yet. So because of that. And you can be doing multiples, and maybe you have some other ways that you've been doing it as well. And I'll suggest you pop that into the chat. People are coming in still. More people have joined, so welcome. This is our monthly webinar for Ontario health teams from the Health System Performance Network. And I am pleased. Okay, let's share that out now. There's still some people entering, but I want to make sure that we can capture this and send it out. So quality improvement being, many people here using it for quality improvement plans. So that's really, really great. Putting that at the forefront. Also, internal measurement and monitoring. Fantastic to see that. To me, this says that you're prioritizing this work internally because it's important to the work that you do. And then some people doing it because it also is in the TPA. And I know that is true for the initial 12 Ontario health teams, and many of you are following that model. Some people are not yet using experience, so we'll see if you can be convinced at the end of this webinar that that's an essential activity for you. Okay, I just want you to be aware of the Ontario Health Team Patient Experience Survey that we developed. You can find more information about it on our website. It stemmed from very early work that we did, starting out practice guides around implementing integrated care for Ontario health teams and what was important to patients and caregivers. And this has come up in a number of our webinars in the past. Carrie Koleski had developed this work, and you can go back and look through many of our past webinars related to there. And we developed a survey tool that captures these 6 dimensions: easily accessing care, having someone to count on, being heard, and knowing how to manage the health and knowing what to expect, and then being independent and feeling safe. And we think that these are essential elements. And in April, we've had Sarah Grace Bebenek from South Georgian Bay, and I didn't catch if Sarah's actually online today, but she often is. And this was work that they've actually scaled this. This is the one OHT we'd like to highlight because they scaled it across their entire OHT and all of the members. So they sent it out to 38,000 people through their primary care providers. Over 3,600 completed responses came back. We were able to analyze this. So for that first one, I have someone to count on. We have results. And this was viewed by them as being the thing that was most important for their patient family council. And they took this to drive improvement. And so they had a number of items related to this, having someone to count on and how they could meet patient expectations on that. So this slide actually comes from their patient family council. We also measured equity as well as those experiences. And we have a number. This one here is just one on income insecurity and whether people had difficulty paying their bills and how much that related to whether they had to wait too long or whether they received care in the right time. So that leads directly into Dr. Grace Spiro and the work that she has done. So I'm going to turn it over to her to let you see a little bit more in depth about this equity and experience dimension.
Wonderful. Thank you, Walter. I'm looking forward to sharing with you today how we applied an equity lens to some of this patient-reported experience data. As a quick background, and as I'm sure we're all aware, measuring patient experience through such patient-reported experience measures, or PREMs, as we'll refer to in this presentation, are not only a key part of the quadruple aim framework, but also allow OHTs to better understand the patient experience and fill in any experience gaps in care. When we also measure the social determinants of health alongside these patient-reported experience measures, we're better able to apply an equity lens to this work and evaluate and understand existing health disparities in the patient experience. The results we'll present today reflect, again, the patient experience survey that Walter has already mentioned, and results from a specific OHT. This OHT will remain anonymous for the purpose of today's presentation, but I have included a few aspects of their population profile to give you a sense of the comparability with other OHTs. Overall, this is an OHT with an attributed population of between 50 and 100,000, majority Caucasian, higher income, in a largely rural catchment. To further illustrate the relative socioeconomic status of this particular OHT, here we have all of the OHTs ranked by material deprivation, which is a combined socioeconomic status indicator using the indicators shown on the left-hand side of the screen. So what you're seeing in this graph are each row represents a different OHT, and they are ranked by the proportion of their OHT that falls in the most deprived catchment. So that dark blue bar represents the most deprived or disadvantaged. And with the red box highlighting the OHT in this case study, we can see that they fall toward the bottom of the graph or are relatively from a higher, a more affluent population. Walter mentioned previously that this patient health experience survey was developed using Carrie Koleski's model here. So just to reiterate that. Today, I will be presenting not all of the results of this survey, but again, focusing in on applying an equity lens. And to do that, we will look at 8 specific patient-reported experience and outcome measures shown on the slide. Again, patient-reported outcome measures are standardized, validated instruments that are completed by patients to understand their own health and well-being. Whereas these experience measures aim to capture the patient's experience of receiving care and their perception of the care encounter. This survey was distributed electronically to the throughout the OHT through the Family Health Team Registry. And for those patients that did not have an email address on file, they were sent paper copies of the survey over a 4-month period. When analyzing these survey results, we completed descriptive statistics and also ran a multivariable logistic regression to understand the relationships between those equity stratifiers and the patient-reported experience and outcome measures. First, I'll give you here a glimpse of our sample characteristics. Overall, you can see that most of the respondents were seniors. More of the respondents were women as compared to men, which likely responds to the intensity of use of primary and other healthcare, but is not representative of the full population or of the OHT. The vast majority of responses were also from individuals who self-identified as white and heterosexual. There were 3 socioeconomic status indicators used in this study. Difficulty paying bills was used, and we also referred to that as income security, having enough money left for food or food security, and finally worrying about losing your home or housing security. To give you an example of how these socioeconomic status indicators were assessed alongside a patient-reported outcome measure, here we have self-reported health by socioeconomic status. The only one of these associations that was statistically significant was that of income security. And here we can see that those who were always struggling to pay their bills at the end of the month were also, or who were the most income insecure, were also had the highest proportion of self-rated poor health. I mentioned earlier that 8 patient-reported experience and outcome measures were our variables of interest for this particular study. So here we can see them actually fleshed out as full survey questions. Again, assessing items related to the patient experience with primary care, asking things like length of time to access your healthcare provider, whether your provider listened carefully to you, whether you felt understood, etc. We created a 2-sided or dichotomous variable from one of the questions, and this was, in the last 12 months, how would you describe the length of time it took to access your regular healthcare provider? So here we can see the results of this specific question, with about 70% of respondents feeling the length of time was about right, whereas about 30% of the respondents felt it was somewhat or much too long. Now we'll expand our look at this specific length of time to access care question, now using our equity stratifiers. So these are the results of the logistic regression, both those that were statistically significant and otherwise. Down the left-hand side, you will see the different equity stratifiers that were used. And again, compared to those 2 groups who felt their care was received in an appropriate length of time versus somewhat or much too long. The statistically significant results are marked with a star, 1 or 2 stars. So you can see that age, there was a statistically significant relationship with both age and housing security. So to illustrate that in a written interpretation, here we have the results. So compared to those who were 65 plus, younger adults were more likely to indicate that their length of time was somewhat or much too long. And we see that those in the 18 to 44 age bracket were 39% more likely to report this, whereas those in the 45 to 64 age bracket were almost 50% more likely to report length of time as being too long. There was also a statistically significant relationship when it came to housing security, whereby those who rarely or never worried about having a place to live, compared to those who were housing secure, those who were insecure with their housing were 25% more likely to indicate that the length of time was somewhat or much too long. Now, we do have the results in a table format like we did for this access and length of time question shown previously. But for the purpose of today's presentation, I'll now shift to share only the statistically significant results by equity stratifier. So on this first slide here, we have the statistically significant results by the stratifier of age. And there existed a trend across all of the experience and outcome measures included, whereby younger adults reported less favorable experiences. So if we look at this specifically, we saw younger adults having lower odds of perceiving their wait time as about right, which we've already shown, feeling their healthcare provider understood their health needs, reporting their healthcare provider listened carefully to them, perceiving their healthcare as coordinated, and so on and so forth. Again, these were younger adults having lower odds of this. When it came to the results by socioeconomic status identifier, so again, though that was our housing, income, and food security, we saw several statistically significant results, and in each case, those who were insecurely housed had lower income security or had lower food security, had less favorable patient-reported experiences. And finally, when we look at the results by gender and sexual orientation, there was one statistically significant association between gender and feeling understood by your healthcare provider, where men had lower odds of feeling that their healthcare provider understood their needs, but there were actually no statistically significant associations between sexual orientation and any of the PREMs or PROM included. In terms of limitations, as you saw, both by the sociodemographic profile of this OHT as a whole and by our study sample, there may be limited generalizability based on the relative lack of diversity of this OHT and of this study sample. There may also be the case of a non-response bias, whereby those who didn't respond were from equity-deserving groups and may have had less favorable views of their patient experience. This would lead to underreporting the results we showed today. But in summary, given the worldwide focus on addressing equity, widespread assessment of patient experience and outcomes alongside such social determinants of health is important, particularly as a tool to promote person-centered care. And in the specific context of integrated care, attention to barriers and enablers for equity-deserving groups accessing both health and social care services and transitioning between these services should also be investigated. I understand that we don't have time for questions today, but do feel free to follow up with me directly if you would like to engage with any of this material. Thank you very much.
Grace, thank you very, very much. And I did started to open a bit of a conversation in the chat, and we have the opportunity for people to use the chat to have an open discussion about this. I asked around whether people who are collecting experience, if you are collecting any information about health equity measures or sociodemographics that would be useful to help you start to see. And I highlighted that one of the real values, Grace, of the work that you've done here is to start to understand where there are differences, that there is variability even within an OHT. And one thing we're very interested in, a number of OHTs have used this tool. We're revising it now to make sure that we can best suit and meet the needs across Ontario health teams. And we had always said we'll be revising. We don't want to be using a single tool forever. And we are interested in engaging people in those discussions about what is most important to patients, family, caregivers, and what can we drive change at. And let's start to unpack some of that. So that's some of the work that HSPN has been doing. I want to now introduce you to the patient-reported indicator survey, because we are not the only people interested in this. Ontario are not the only people interested in this. This is a global effort that has been recognized by Paris in the Paris surveys, and we've been supporting this work for the last number of years. And we'll have a few speakers now talk about this initiative. And really starting to have Paris as the basis for comparing across health systems, that it's not just about some clinical marker, it's actually achieving the health outcomes and positive experiences. So 2 of those domains, and we will again also look at equity. So 3 domains of the quintuple aim framework. I'm going to go quickly just to introduce, you can't read this slide. It's not meant for you to read. It's just intended for you to know that Paris was developed understanding facility, organizational system design, patient-reported experiences, what patients' own health is, and what their behaviors are, and how those then lead to overall outcomes. So this is the entire framework. The final survey had 137 items on it. So people who responded to this survey, and there were many, made quite a time commitment. We need to really maximize the value of this tool, and the intention now is it will become a standard international tool for collection every couple of years. I'm not going to go through all the items. I'm going to dive into just 10 of the areas that are now in the report. That QR code points you to the OECD website, where you can find the Paris surveys and the report that was released literally fresh off the press last Thursday. We were unable to be as public about our dissemination until the OECD had their release, which was in Portugal last Thursday. They have 10 measures at the top, some of them on PROMs, 5 on PROMs: physical, mental, social health, general health, and overall well-being. And then in the area of patient-reported experience measures, they have mostly scales, but they have 1 item on confidence to self-manage. And most people in the health system are really driving towards the value and importance of this capability. And then there are a number of scales around coordination, person-centered care, and overall experience quality, which is very much like the Commonwealth Fund of an overall experience quality. And there's a question across health systems around trust. Let me just pull into just a few of these results. The definitions are here for those who can come back later and see more specifically. So let's go past this. And the experience, great. So just to let you know, I'm going to show you results from 107,000 people from across the globe, from 19 countries that participated, 17 being OECD members. In Canada, because we didn't have a registry, some countries had a registry of all the primary care practices, like a list of all the primary care practices in the country. Imagine that. It's a good way to help people get attached to primary care if you actually know where they are. But we had a convenient sample. We put out a call and we invited primary care providers to join and then distribute surveys for us. On the next slide, you'll see that we've been participating in this, and we've been supported here in Ontario by the Ontario SPORE Support Unit. That's a CHR-funded entity, co-funded by the Ministry of Health as well, and we receive funding from them to support this work. In Canada, almost 4,500 patients are participating and either partially or entirely completed the survey from 52 practices. And I'm going to show you, when you see Canada's data, the next slide shows you who participated from across Canada. So 5 practices from BC, 8 in Alberta, 10 in Manitoba, 8 in Saskatchewan. No, that's Alberta, 10 in Saskatchewan. Do I know my geography? 13 in Ontario and 15 in Quebec. And we're going to see a lot of the results from Ontario and Quebec today mostly, but all of Canada's results On the next slide, you'll see we're starting to prepare these reports, and these will become imminently available now that they've been released publicly by the OECD. We have a national report, and we have provider reports for in Ontario. And you can also, on the previous link to OECD, see the OECD overall report. And we're also providing practices back their own survey results in comparison. And you're going to see a lot more about how we're doing that. Okay, just a flavor of how does Canada look compared to the other countries. So this is our physical health compared to the respondents. So this is the physical health for people with chronic conditions in the darker blue and without chronic conditions in the lighter blue behind. So always people without chronic conditions have slightly higher health. You can see actually our health status. There's not a huge amount of variability across the countries. We are near the top, but there isn't, as I mentioned, a lot of variability across this. In our mental health, on the next slide, we're just slightly down. There's quite a bit more variability in this item, mental health scores for people, and we're still doing relatively well to other countries. The respondents to this primary care survey reported better mental health than that from other countries. And these are kind of standardized scores. So I can't give you a direct interpretation of that score just below 50. It's been standardized to have the score across all countries be 50. And then it's all relative to that. So on the next slide, we have these results reported by province. So in our own national report, we will take this data and unpack it by province. And so you'll be able to see. And, there is some variability in self-reported health across the provinces. Ontario has apparently fairly good, with more people with excellent or very good health, but also still some people with fair or poor health. We also have the self-reported mental health as well. And bothered by emotional problems is how this is recorded right here and now. Again, variability across the provinces. So that's the kind of overall health. I want to talk more about the experience items. So in the Paris survey, I want to come back to that confidence to self-manage. You see, this is an area where Canada could still be improving. There are many countries that feel that they're in better position. In France, the Netherlands, Saudi Arabia, Czech, Switzerland, all better than Canada. And there are a few countries that are not as strong as Canada, but still lots of opportunities for us here to improve. And I think that's really essential and part of what we're really trying to drive at through patient engagement. We also can look across the country in this. First experience coordination. That's fine. Okay, great. If you can go back one, Lale. This was a slight edit. This is experienced coordination of care. So how well is care coordinated across Canada as reported in comparison to other countries? So there are places where it is better, Australia, Switzerland, Romania even, being better coordinated, but we're actually doing reasonably well compared to other countries. And now let's see, within Canada, also talked about, what's important to people in managing their health and well-being. So this part here is one of the sub-items on that good coordination that they have, what's discussed about you. And we see some variation across the provinces. Manitoba doing a little bit worse than other provinces, but also all the provinces having lots of room to improve. There's still quite a bit of area around the red and yellow here, which would be areas to improve. On the next slide, we actually just want to show you that this varies even within Ontario. These are 13 practices that participated in this tool, and you see quite a bit of variability even within the practices within Ontario. So practice 2, about 58% said that they always discussed what was most important to them, whereas that was only 35% in practice number 8. On the next slide, the last point I'm going to make, are people involved as much as they want to be in their care decisions. And here also we see a fair bit of variability. Practice number 2, more than 85% always. And then in practice number 8, only 45% saying always. So really opportunities for improvement here. And this is the kind of work that we need to be able to do to generate and demonstrate value. But I want to know, I'm going to ask Yasmin now to come on. We're not just doing this from our perspective as researchers, but really trying to share and discuss and engage with what is important to patients, family caregivers. So Yasmin, I'm just going to ask you, maybe you can comment on this today.
Yeah, of course. Thanks, Walter. And hi, everyone. I'm Yasmin, and I'm a patient partner on the Midwest Toronto OHT, and I'm also the patient vice chair. And so I chair our patient and caregiver advisory council. And I'm so grateful to share a bit of my personal story today and highlight the value of patient-reported indicators in shaping better healthcare experiences. And I wanted to start off by saying that these indicators are so much more than just numbers. They represent our voices and our lived experience. And to give an example of the story behind an indicator, I wanted to talk about two of the indicators that Walter just highlighted that really resonated with me around involvement in decision-making. So the ones around how patients are involved as much as they want to be in care decisions, and patients discussed what is most important to managing health and well-being with their provider. And to me, these indicators really strike at the core of patient-centered care and empowerment. And the reason why these indicators spoke to me is because of my experience as a patient. And for background, it took me a long time to feel fully involved in decisions with my family doctor, and feeling heard by my physicians and participating actively in care made a big difference in my treatment plan and healthcare experience. And I wanted to give an example of how my involvement in decisions around my own care changed my treatments for the better, thankfully. So just to give a little bit more background, I've had high blood pressure for the past few years because of my kidneys, and I also have ADHD. So the treatment for ADHD is stimulants, which can raise your blood pressure. And because of this tricky situation, my specialist took me off stimulants completely and put me on blood pressure medication, which is an approach that is in line with best practices, but didn't exactly consider the impact this would have in my daily life. So this had a devastating impact on my work and school. So I'm doing a PhD, as Walter stated in my intro, and that involves a lot of writing, and writing that I just couldn't get done for the 8 months I was off my ADHD medication. And I also had bad side effects from the blood pressure medication too that they put me on, like just brain fog, feeling tired all the time. So my family doctor eventually sat me down and asked me how I was doing school-wise off stimulants, to which I told him that I wasn't doing well at all. And I remember that day because he looked me in the eyes and he said, "Let's find a solution that works for you." And long story short, after a lot of trial and error for a few months, we were dedicated to finding a solution that worked for both ADHD and blood pressure. And I ended up on a low dose of ADHD medication and a new blood pressure medication that works really well for me. And I just have to take my blood pressure, measure it every day to make sure it's working, and it is. So this is a happier story, and I'm sharing the story to show how my family doctor involved me in decision-making, and we worked together towards managing my health and well-being. And I see this as so important because patients shouldn't just be passengers in our healthcare journey. We should be co-pilots, and primary care providers can make that a reality. And if I were to complete those survey questions today, my responses would be positive, but this isn't always the case for patients. And in most of my healthcare journey, I have not been involved in decisions around my own care. So happier outcome, but a really tough journey that I've been through. So documenting patient experiences is crucial. It helps us see the bigger picture and also areas where we can improve too. And most importantly, it's a way of amplifying our voice and moving us towards a health system that is truly centered. So I'm bringing this up, but I also wanted to talk about this event that we had to talk to patients and families in November. So HSPN held an in-person Café Scientifique in Toronto, and this event was about putting patients' experience data into action, where we had group discussions around ways to capture and share survey data. And I wanted to highlight just 3 key themes that really came out of this rich discussion at the event. So the first theme is on surveys as a valuable feedback tool in primary care. And attendees at the event, they spoke about the valuable insights that surveys can provide on patient experience and how they're essential for capturing patient perspectives and also identifying gaps in care. And attendees also highlighted the need for short, accessible, and co-designed surveys with patient-centered feedback mechanisms, and to really make the most out of the value surveys can have, attendees stressed thinking through issues like anonymity, equity, and inclusivity to ensure that we have diverse populations represented. Then the next theme was around the need for systemic and organizational accountability. And attendees here, they highlighted how surveys should actually influence primary care practices and policy decisions. So we should be seeing these changes in practice, and how there should be incentives and accountability mechanisms in place for providers, in addition to co-designed solutions that can drive service improvement. And then the last theme was on promoting transparency and data sharing. So attendees really emphasized how survey results and practice changes should be communicated to patients in an easy to read and clear format, such as through infographics or on a website, to promote transparency. And they felt that patients should be updated on how their feedback leads to care improvements, and that patients need to see how their feedback is influencing change to encourage continued participation. And this, of course, also applies to providers as well. So keeping both patients and providers in the loop. And we can't just do this with patients or just with providers. We need all perspectives to really optimize change. So this is just a very high-level summary of some key themes that stood out from our engagement in November, but we're also going to have another one of these events in March with patients, so you can sign up for it. I think, Walter, will you go over where to sign up for it?
Yeah, great.
Oh, I guess there's the QR code there.
Yeah, we did exactly that. So thanks, Yasmin. It's so important, and Yasmin, we really appreciate your always bringing your perspectives and also helping us design these events where we can bring many patients, family, caregivers together from across the health system. And I really think that when we're doing patient experience, it is about ensuring that we are capturing what is important to patients, family, and caregivers. That's our purpose. And so these events, like the one we held in November, and this one, it's coming up on Thursday, March 27th. You can register here. We will make this also, we'll be emailing out everybody the opportunity here. Our focus here is for patients, caregivers, and citizens. And in fact, we're going to have a predominance of that. And if we have many people who are non-patient people signing up, we might restrict access a little bit just to make sure that the patient voice comes through. And we don't want to overburden. So we're asking people to be able to kind of do that and bring up your perspectives. Thanks very much again for sharing that, and I'm really looking forward. We are now coming up, and I think we have just flipped over to a presenter view, so we might need to flip the screens, at least from what I've seen. And now it's just me. Here we go. So I'm queuing this up because now we want to know is not only is it important to talk to patients, family, and caregivers, but this work needs to be embedded in care and part of how the health system responds. And so here, of course, wait there. We have with us today Dr. Marie-Ève Poitras. I'll ask Marie-Ève to come on screen and take herself off mute. And we didn't have a chance for an audio because Marie-Ève was doing another webinar at the beginning as we started this. She's very in demand. But thank you for joining us today. And Marie-Ève is going to talk to us about some amazing work they've done in Quebec that we're learning about in how to translate this back to primary care practices.
Oh, thanks, Walter. So as my colleague previously mentioned, I'm a late arrival because I was in another conference, but I am Marie-Ève Poitras, a researcher and a professor at Sherbrooke University in Quebec. I'm also a registered nurse by training, so I've been involved in primary care practice prior my academic journey. I am also one of the co-lead of the Paris OECD project with my colleague Sabrina Wong and Walter. So nice to be with you, everyone, today. So first of all, next slide, please. First of all, when I've been involved in the Paris OECD project for the Quebec province, I was really aware about the fact that I want those results meaningful for primary care practice, primary care provider, and patient. So when we had the opportunity to launch and to collect data in Quebec province first, when we recruit the data, the practice And when we talk with the healthcare provider in primary care practice, we create a project which we were able to share and to present the PROMs and PREMs data come from Paris OECD project in Canada. And what we want at this time when we're beginning the Paris project is to share those data, and we want those data useful for primary care provider. So it is with this in mind that we create a knowledge to action intervention based on the quintuple aim to support a primary care provider experience, patient health, and patient also experience in primary care. So we create an educational intervention where we share the PROMs and PREMs data, and we talk with the healthcare professional about what PROMs and PREMs data could become good and meaningful indicator to support primary care organization and services in the practice where Paris OECD were involved. Next slide, please. So with this in mind, this is quickly the overview of the Paris OECD project, but what we have to understand is that with Paris OECD project, the only mandate was to collect data and to share those data to the OECD organization to compare Canadian data to other country. But we want, has a Quebec lead, but also all the Canadian team want those that are meaningful for primary care practice. So we didn't want just to take the data and don't send them back to the primary care provider. We want to create a collaborative team and relationship with practice that they were involved in Paris OECD. And when we sell the Paris participation, we also sell the fact that we send and share the data to every practice in Quebec province, and we will work with those providers to see how those data could be routinely and used at certain period of time by a practice manager, healthcare provider, and IPT member to become a standard. So a high quality data that they can use to support that are primary care organization. This is quickly the framework and the background that shape our methodology, but we are also implementation scientists and KT. We have a big KT interest, so we create this project to be to engage provider and primary care practitioner in our Paris OECD survey. But also we take this opportunity to have a reflection with primary care provider about how we could integrate and implement PROMs and PREMs routinely and cyclically, in primary care practice and primary care network in Quebec province. Next slide, please. So in this, we create dashboard. Those are the so for the Canadian project, we have 65 practice and more than 4,000 patients. But what we in Quebec, we have around 15 practice and more than 100 patients, 1,000 patients, sorry. And we had also practice that they were francophone, but also anglophone. We developed with our Canadian colleague and provincial coordinator in each province a 4-page final template where we share the same indicator and the same PROMs and PREMs data. So it was a first cycle of template because Paris OECD has a lot of data that can be present to primary care provider and practice, but we choose together what could be the first domain and subdomain of PREMs and PROMs that we could present. Next slide, please. So first we create the dashboard, and after this we create also the virtual or in-person learning session. So first of all, we create a scientific committee to create the PowerPoint, but also all the reflexive activity that we want to do with the primary care provider. We also get an accredited learning session from the Sherbrooke University, so family physician can have and other IPT member can have credit B for continuous education activity. So it will be really, really interesting for primary care provider to engage in those discussion sessions, but because they know that they will get credited for those discussions with the research team. And after this, we also give to each a provider, but also primary care practice manager, a hard copy, a paper copy of the dashboard, but also short report of our highlight and our analysis about how our PROMs and PREMs in their primary care practice compared to other Quebec provincial practice, but also compared to other Canadian data that we have during the Paris OECD project. You have on this slide the presentation plan, but first of all, we present the meeting objective. We also do an introduction about what are PREMs, what are PROMs, and an interesting fact is that in Quebec province, PREMs do not refer to patient-reported experience measure, but most of the affectation of family physician do. So this is an acronym that the the Provincial College of Family Physicians use to give some position job to family physicians. So when we start to work with primary care provider and family physician more particularly, and we talk about PREMs, we have a semantic and we have a language barrier in terms of PREMs. So we have to educate a little bit about what PREMs are in terms of patient experience. After this, we also present the Paris study summary, the timeline, and how the thing that we have done to have to get our sampling clinic level, practice level, and how the data collection process. After this, we present the dashboard, and we have some discussion about the relevance and the perceived relevance and how those PROMs and PREMs data that we present during the in-person or virtual session are meaningful and useful to support primary care organization. We test the both situation. So we do virtual learning session, but we also did in-person learning session, and both are positively well received. But I personally prefer in-person learning session, as we can see the nonverbal behavior of the IPT member, and we can have more in-depth discussion regards our result. We also found that the in-person session support better engagement during discussion, but also engagement regards PROMs and PREMs integration, because we observed that the pre-meeting discussion and the after-meeting discussion could lead to other research or quality improvement opportunity in collaboration with our research team. So it's really, really positive to just take the car and go meet the interprofessional team member or primary care provider in practice meeting. Next slide, please. So this is an example of the dashboard for the Quebec province. So first of all, we explain what is the dashboard, but also the limitation and the strength of those dashboards. So we present descriptive data. We also mentioned to the audience that there is some limitation in terms of sampling, number of participants, and the way that people can take those results as cash, may I say. After this, the second part of the first page is all the enrollment and response rates for Canada, but also for the province. And every practice is the darkest blue color, so they can see how they situate themselves compared to other clinic or other province. Next slide, please. After this, we have the description of the sampling in terms of general information. We try to be similar to every practice, but we were able also to highlight some specificities. Depend on the practice, if they are rural, suburban, if they are also what is the average age of the participant in their sampling. When we met the primary care practitioner, we see that people are really interested to see if the characteristic of the sampling is similar to the characteristics of the patient that they see in their clinic. Sometimes the characteristics were similar, sometimes they were not. What is really, really interesting is that it's not important for the quality improvement discussion if the characteristic is not similar, because we have some question to ask to practitioner about if this sampling is not similar that the patient that you are seeing in your daily professional life. What is the difference? How do you could use those results to and transfer this to the patient that you represent and the patient that you see in your clinic, in your clinical practice. Next slide, please. After the characteristic of the sampling, we were interested to present the PREMs, so the experience of care and the health outcome. Mainly, we focus on this first session because, as I previously said, Paris OECD project has a lot of data and indicator that we can present, but mainly we focus on discussion about the time of the consultation, how patients were involved in the decision that they have to take. So we refer to shared decision making. We were also interested about the patient-centered care perspective, about to be considered as a whole person, but instead of a chronic of a disease only. We were also interested about the relevance of the appointment of care. So did I see the family physician today, tomorrow, in a week, or in a few weeks after my needs? And for the health outcome measures, so the PROM, we were interested about the general health, about the pain, about emotional distress, about management of health and well-being, and about the quality of life overall. What we observed when we also present those data to healthcare professional and family practice manager is that results are really positive, and people are really happy to see that most of the patients that they've seen in their clinic positively rate care experience and their health outcome. But 2 points. We observe that family physician and interdisciplinary team member are really interested about the opportunity of improvement, so that they are really interested to know what are the characteristics of the patient that they don't perceive their health as positive. What are the patients that they don't experience positive health experience? So they were really interested about the dark blue line, and they're asking us for more statistical analysis to be able to have more detail about who are those patients, because what they want is to be able to transfer those data and evidence come from Paris OECD to the characteristic of the patient that they are seeing in their daily practice. We were also surprised to see that there is some difference between, as an example, about the overall quality of life, of the overall perceived health status, that people mentioned that they are, family physician mentioned that they perceive probably the patient most sick than the patient see in himself. And so we talk a lot about this. We talk a lot also about the sampling characteristic, and they will possibly also bias in terms of number of patients that they answer the questionnaire in clinic, but they were really interested about to see the discrepancy between their perception about the health of their patient and the way their patients perceive their health condition. Next slide, please. Finally, during the discussion, we also do a lot of prioritization and discussion about which is the data that is most important for your healthcare organization. What data could be really useful for your own professional practice? What is the data that could support quality improvement opportunity? We also use in some practice and in some in-person or virtual meeting a prioritization matrix, where we use the result to identify the opportunity to improve primary care services. And we also have discussion with healthcare professionals and team and attendees about what are the things that they have to do to improve these indicators or to maintain, because as the PROMs and PREMs data presented in Paris are really positive. We also use those data to talk with primary care provider about what are the good things that they are doing in their primary care practice and what things they have to do to maintain those excellent standard in their practice. And the way we question in the attendees, we also bring them the importance of in the situation there is a professional worker movement, when we have workforce problem in primary care, we have to identify in our primary care practice what's work well and what we have to maintain. And this will help provider and primary care manager to support the arrival of new worker in the clinic or new family physician or student, to be sure that the high quality standard that they have already in their clinic is maintained over the time. Next slide, please. So we do a post evaluation of our in-person or virtual meeting, and most of the time, the majority of the attendees highly value the activity, the quality improvement activity. Also highly value the way that we share PROMs and PREMs, and they find PROMs and PREMs really useful and good data sources to orient care organization. We don't pretend here that PROMs and PREMs are the only data sources that could be used to support healthcare organization in a primary care practice. But what we want to is that we believe that PROMs and PREMs have to be had to other health data sources to support primary care organization, because it gives another side of the box to take better decision and to be sure that we hear patient voice in our healthcare organization and transformation. Next slide, please. So this is an overview. So most of the 90% of people agree that PROMs and PREMs are meaningful and valuable indicator, and majority 9 people on 10 people plan to change and to commit to do change in their daily practice or at the clinic level based on PROMs and PREMs that we share during the in-person or virtual meeting. Next slide, please. So mainly dashboard are appreciated by provider and clinic manager. Attendees to our activity find that PREMs and PREMs is useful data sources to have reflection about what is valuable for patient and what is the gap between primary care perception and patient perception. They also find useful the way that it was the first time that they have feedback in terms of care experience, and at the beginning of the Paris OECD project, a lot of practitioners were afraid about the PREM scores. So because they were afraid about what can I do if the patient doesn't find that the clinic works well, if the patient find that I'm not patient-centered, or if the communication is not good. So people were afraid to do not have leverage to improve patient experience regards the results. So in fact, we observed the inverse. So PREMs is mostly positive in most of the primary care practice in Quebec, but also in Paris OECD, in Canada. But there is some space for improvement, and this is what practitioners find really, really relevant. So next slide. So thank you. I hope you enjoy my presentation. I will be really interested to discuss and have more discussion with you. Thanks.
Yeah, thank you very much. And don't go away yet. I'm going to wait to see if the audience may have some questions. But I've got two for you. One is first I want to thank you very much for putting all of the work that you did into taking all of those like massive amounts of data collected through Paris and turning it into something that could actually make change happen. And we've learned, and I think one of the insights I learned from you, I also learned from another one of our postdoctoral fellows who's doing some audit feedback work on our actually approach, because we feed data back, Dr. Victorentes, about the importance of identifying the issues, providing some comparison, and then giving people an indication of what they could do about it. So what kind of extra investments did you have to make in order to pull some change ideas? Where did you get all that?
We did a lot because the first time we do the in-person or virtual session, we was thinking that only present the data would be a leverage to suscitate discussion and reflection about quality improvement opportunity. But what we observe is that our primary care provider colleague in the Paris OECD project need input from us in terms of what we are seeing, what are the good results, what are the opportunity of improvement, and they need help to raise a little bit red flag about the data. This is the first thing, and this is why we just we modify a little bit our dashboard to be sure that we have, this is what we see, this is important for you. And the second thing that we also did, is that we conduct quickly rapid review in certain topic, patient experience, communication, team-based care, and those things. And we give some evidence-based recommendation based on our rapid review also, to be sure that this is not only my team that they give an advice to another practitioner, but it's really informed and evidence-based recommendation.
Yeah, thanks very much. And that really harkens back to, you know, we've taken a bit of a learning health system approach more so in the last year to the work that we've been doing. And I think just understanding that, you know, there are many aspects to improvement, and data is an important and essential aspect to improvement, but so is co-design, so are these sessions, so is the evidence base. So I think you've kind of got a few of those gears running there. You've got data, evidence, and co-design happening. It'd be interesting to follow up on some implementation changes of things that were happening. I have other questions to you about team and physician and other types of involvement, but I'm gonna leave it to the participants to maybe put some other questions or thoughts in the chat. And I gotta move on so we can have some of our other pieces. This is just an example. We're copying you and taking what you've done, and we're using this format to provide practice reports back here in Ontario as well. So thanks very much for your generosity as well in making this actually easily available in Canva for us to use. Lovely. I'm going to introduce now Emily Hamovich, who's been back-ending it. Emily actually helped us launch the Paris survey and provide all of the data and ensure that we have the data to do this, and is a very enthusiastic participant in the network. So I'm going to turn it over because we're actually trying to take up the work, not just from describing, but to understanding. And that requires a little bit more of our researchy kind of hats and analytic methods, and Emily's expert at that. So Emily, let me turn it over to you to explain so you can help us understand.
Great. Thanks so much, Walter. And thank you for having me today. And a bunch of tough acts to follow today for sure. But today I'll be presenting using the Paris data, like you mentioned, Walter. And this is specifically focused on factors that are associated with patient satisfaction in primary care settings. So to provide you with some background, as discussed today, patient-reported outcomes and experiences are well recognized now for quality monitoring and improvement. So PROMs stands for patient-reported outcome measures, gather information related to health, functioning, and quality of life, whereas PREMs, also known as patient-reported experience measures, focus on patients' experiences while receiving care, which reflect organizational care processes. And this is really a way to address inconsistencies between patients and healthcare providers' assessments of patient needs. And it's also a way to provide data on quality healthcare from the patient's perspectives and can contribute to quality improvement cycles as well as clinical and policy decisions. However, such measurement to date has been quite limited in primary care. So the OECD, the Organization for Economic Cooperation and Development, which was previously discussed, provides international standards for reporting on health system performance. And they identified increased public interest in ensuring that patients receive care that is responsive to their needs. And so accordingly, in 2017, as you heard, it launched the Patient-Reported Indicator Survey, also known as PARIS, to build capacity for PREMs and PROMs in primary care. And in having this data, we recognize that there's a need for research on practice level as well as other provider level factors that influence both outcomes and experiences that contribute specifically to satisfaction with care. So the sample for the study consisted of a convenient sample of patients and their providers who were surveyed across 16 practices within Ontario. The eligibility criteria for the patients included age 45 years or older who had visited their provider in the past 6 months. And then one representative from each practice was surveyed to collect practice level data. In terms of distributing the survey, patient surveys were sent through a generic link through their practice. So rather than the link being sent out by the research team, this was sent out by the practice as a way to increase buy-in. There were 2 surveys that were disseminated. First, a practice survey that was disseminated to providers, and then a patient survey that was disseminated to their patients. So the practice survey consisted of 34 questions about practice characteristics, such as location, practice type, funding models, team compositions, and services that are provided. And then the patient survey consisted of far more, 121 items that covered 4 domains. This included health status and symptoms, managing health, experiences of primary healthcare and services, and lastly, experiences of other healthcare services, as well as sociodemographic characteristics. And embedded within these domains were PREMs and PROMs. So PREMs included questions that were focused on access, comprehensiveness of care, quality of care, person-centeredness, continuity of care, self-management support, safety, and trust. Whereas PREMs had questions pertaining to symptoms, functioning, self-reported health status, mental health, pain, sleep disturbance, fatigue, physical functioning, satisfaction in social roles, and self-management capacity. For data analysis, descriptive statistics were used to describe patients' characteristics, as well as the types of practices that they were a part of. And patient satisfaction was assessed with the question that asked, when taking all things into consideration in relation to the care that you have received, overall, how do you rate the medical care that you've received in the past 12 months from your primary care clinic? And then exposures included patient level and practice level characteristics that are shown here on the box on the left-hand side. Univariate ordinal logistic regression models were run to determine patient level and practice level characteristics that were significantly associated with patient satisfaction. And then all significant variables from the univariate analysis were modeled using a random effects multivariate ordinal logistic regression. In terms of demographics, patient demographics, our results showed that the majority of these participants were aged 55 to 64. Most had completed a community college or post-secondary program. The majority identified as women as well as white, and the sample was distributed quite evenly among income groups. In terms of the provider demographics, among the 16 practices who participated in the survey, the majority were physicians in family medicine. Most were practicing in an intermediate density area and had a group practice with their own patients. This slide here shows the results of variables that were significant in the random effects model, as shown in the red font. So specifically, patients who preferred not to reveal their income had significantly lower satisfaction scores compared to those who had an income of up to $60,000 annually. Patients who are always or usually stressed or worried about having enough money to pay their rent or mortgage had significantly lower satisfaction scores than those who are never worried. Patients who rated their health as very good or excellent had significantly higher satisfaction compared to those who rated their health as good. And patients who had appointments that took place between a few days or up to a week, on the next day and on the same day after initially booking the appointment, had higher satisfaction scores than those whose appointments took place more than 1 month later. And then lastly, patients who went to a clinic where the head of the practice was a nurse practitioner had significantly higher satisfaction scores than those who saw a physician. So the results show us here that financial instability is significantly associated with low patient satisfaction. And this really validates the consideration of materially deprived patients as a priority population. There's a growing literature on potential primary care interventions to address poverty as a social determinant of health. And these include screening tools to assess social needs, welfare rights services such as social prescribing, food and security interventions, and promoting healthcare's involvement in affordable housing. However, unfortunately, the potential of these interventions is limited as primary care lacks strong linkages with social services, and navigating these systems can be complex. So this is certainly an area for future research. Wait times for appointments were also seen to influence patient satisfaction, with shorter wait times resulting in higher satisfaction. So it's been well established that accessibility and availability are important characteristics of efficient and effective primary healthcare systems. And longer wait times for primary care appointments are associated with poorer outcomes, and individuals often have no choice but to rely on urgent care. There are a number of strategies that are being implemented to address this problem. This includes having incentives for family physicians to provide additional services on evenings and weekends, and improving other structural interventions such as open access or advanced scheduling, which is focused on reducing and eliminating delays without adding staffing resources, by keeping a majority of short appointment slots unscheduled and only filling them on the same day that patients call in for appointments. Also, paying attention to the use of teams in primary care practices that include nurse practitioners and allied health workers. And finally, capitalizing on the use of electronic communication and telephone follow-ups to reduce unnecessary and time-consuming face-to-face appointments while maintaining continuity of care. Finally, patients who were seen by a nurse practitioner had significantly higher satisfaction scores than those who saw a physician. And this is also mirrored in the literature. One study that was conducted with patients who were referred to nurse practitioners in the Netherlands found that satisfaction scores were slightly higher for nurse practitioners in comparison to general practitioners. And the preferred score for nurse practitioners were found for items relating to length of consultation, reassurance about symptoms, information on coping with disease, and attention to the impact of disease on daily life. And in Canada specifically, nurse practitioners have been integrated into primary care to address the doctor shortage problem and to improve patient access to care, as well as lower costs. And across the globe too, nurse practitioner work has been integrated into primary care settings. And this has resulted in individual, community, and societal benefits for vulnerable populations, as well as cost savings and increased access to care. So in conclusion, the findings of this study shed light on several factors that enhance patient satisfaction, including income, self-assessed health status, wait times for appointments, and professional background of the provider. And insights into the factors that are underlying patient satisfaction can help health policymakers and providers to design services and allocate resources to really improve the patient experience. So structuring primary care in ways that address the social determinants of health, drawing on skills and leadership of multidisciplinary teams, and creating efficient systems for reducing wait times and attending to patient perceptions of their health and ability to function in their daily lives are actions that may enhance patient satisfaction. Thank you.
Wow. Thank you, Emily. And it's really been a pleasure to learn. I just, I'm listening to you talk about the importance of, among other factors, wait times in overall patient experience and their satisfaction with the practice. And then I'm thinking back to what Grace said earlier on, that the suitability of the access times varied according to sociodemographics, and how we can then, so improving overall experience, look at access, but then we also need to think about where that access is not equitable. And so I think that, sort of tying a few of these pieces together and trying to understand how do we move ahead. I am interested from the participants today. It's actually been, a moderate chat. There's actually been some really interesting contributions being made, but there's actually one of our very well attended webinars, well over 100 people early on, and we maintained a pretty high, above 80% past that 1 hour mark. So I know people are very engaged and very interested and keen on this talk. So just really interested in your feedback and what questions that you have. And as you think about putting patient-reported measurement in your OHT and the providers within your OHT, what are some of the challenges that you are foreseeing in that space? Magdalena's got another chat point here, and really having an opportunity to learn more from others about how client feedback is being implemented in workplaces with limited resources or administrative support. And I know that is like how to do this work We think about this as like low resource evaluation in a way, and how to embed that practice and not make it too overly complicated, but build in sort of low cost ways of gathering data, because it's not something that you are very familiar with. And I think sometimes partnerships with researchers and having some academic support to OHTs is quite useful, because we can think of low resource ways for you to do things. And you know, we have a little bit more. We're using Zoom now to gather feedback. For very long time, we were just using a Google Doc form to collect feedback following these webinars. That was just one of our ways. And now you'll get prompted when you're leaving, because we've become a little bit more sophisticated about taking care of the tools. I'm just going to let you know, there was a third of the people here today didn't know about our webinars, or hadn't been. Maybe you knew about it. You're just kind of like, yeah, it's not very important. Oh, PREMs, that's interesting. Patient experience. So we've been thinking about what to do next month. We have a couple of things on the plates. You know, we have only started this conversation around PREMs and PROMs. And I know particularly in the space of primary care, we didn't have a chance to dive too far, but Marie-Ève was working in practice settings. And one of the next question on my mind was, there seem to be teams and doctors and teams. And here in Ontario, we don't always have those two together. And so how to do this in primary care, particularly amongst the vast amount of primary care that are not embedded within teams and don't have some of those extra resources that maybe others do. That's an area that HSPN is very interested in supporting and advancing in Ontario. And for many of the OHTs, like we've done a lot with one that had a massive family health team and was able to, you know, actually cover their population. But that's not the case for many places, and we need to do a better job. If you pop up the poll, I'd just be interested in the people who are here now on what you thought. We've got a couple topics here. I'm just interested in just a little snap poll on if you looked at next month and you said, oh, there's going to be more on PROMs and PREMs. Oh, I want to learn about leading projects in home care. That's an interesting space. Oh, you know what? We really need to have some input on governance and leadership. And there may be other topics of great interest to you, at which point you should just tell us. And you will also have an opportunity, if you don't do it here, in the post-event survey comments. Just, we also always ask, like, you know, you have suggestions for the future. We ask, like, if you found it useful, and if you have suggestions for the future. Basically, it's those two questions for the most part. So you have an opportunity there. We can share back. Jaleesa, we are going to do our very best to update our invitation list based on people who have registered for the webinar. But if you go to our website, I'm sure there's a way to connect to us. And at worst, you can email oht.evaluation@UToronto. Put this in the little chat box down here. You can always contact us at that email. And if we shared these results back out, I think so. So more on PROMs and PREMs, still a hot topic here. Leading projects in home care, a close second, and governance and leadership being important to many, but not quite on that top rate. So thank you very much for joining us today. Look forward to next month, and also your feedback on today's event. Very great thanks to all of our panelists, superstars. I'm learning so much about this space from them. Thank you very much for coming and sharing your patient experience, your feedback to providers, and the research that we have going. Thank you very much. Have a great afternoon.